estimation that 16 million people live with chronic back pain, and up to 65 million patients in the United States have acute back pain at some point in their life. We're fortunate at Riverside that we have a large team, 5 neurosurgeons, who manage complex spine disease from minimally invasive, small operations, through little ports to big deformity operations, to cancer surgery, and we take care of the trauma population as well, which tends to be fairly complex. And we're well equipped to have all the modern technologies and training to accomplish that safely and effectively.
Decompression just means freeing up nerves. One of the most fundamental things that we want to accomplish in spinal surgery is to free up nerves, because the pain caused by a pinched nerve, which people commonly refer to as sciatica, is very difficult to treat without surgery. There are some strategies, but ultimately many of these patients require that we physically go in and remove the pressure on the nerve. So we call that decompression. Fusion means sometimes there's something called instability. Vertebrae are moving out of alignment. Or sometimes we know that in order to get the decompression done, we're going to have to remove enough bone and ligament, supporting tissues, that it's going to make the spine unstable. So to compensate for that, we do a fusion. Fusion just means we find a way to link the 2 or 3 involved vertebrae so that they're basically glued together. That often involves removing the disc, the soft spacer between the vertebrae, gently scraping it out, and putting something called a cage or spacer. Basically a device made of titanium or a durable plastic that's hollow, so it fits very snugly where the disc used to be. It joins the 2 vertebrae, but because it's hollow, we can pack it with little pieces of bone that we recycle. We obtain that from the decompression, and over time, the natural response of the body is to grow new bone. In the same way that, say, a fractured arm or leg will heal by forming a callus, forming new bone, when you do that fusion procedure, typically the body will grow a bridge of bone. We will typically put screws and rods to link those 2 vertebrae so that they're immediately stabilized, immediately locked together, and that helps the body to create the fusion process. The traditional approach to the spine involves a midline approach. We make a vertical incision down the midline, and usually in the lower back. But in certain cases, you don't need to do that. And the reason it's beneficial, when you do a midline approach, it does require that you spread the muscles of the lower back, which are quite hefty, quite a ways out. And so it's traumatic to the spine. Spinal navigation, I think, has been a game changer in that, allowing us to do it with virtual guidance, basically a GPS for the spine, which allows us to work so much more efficiently. Some of our procedures are minimally invasive. It's day surgery. Patients go home the same day or the next day, and with some basic instructions, they can recover just fine. But when you're talking about bigger operations, a spinal fusion, certainly a spinal reconstruction, this really does disrupt your core. So physical therapy, occupational therapy are critical in helping folks to safely get to these goals step by step. This can sometimes mean simply setting up a home health agency to provide some basic therapy at home, which often will transition to outpatient physical therapy. But folks that have more acute needs, a lot of times will benefit from inpatient rehabilitation, where they actually go to a facility and participate in about 3 hours of rehab a day.
I think ultimately what's considered quality in a spine surgery program is outcomes. How do patients do? Whether we can get you back to living your normal life and doing the activities that you want to do, putting you back in the community, and you're our neighbor, so we care.